because
Okay.
there's a lot of verbiage on those two that are kind of confusing. And I thought, well, this is probably going to come up in a minute anyway, so let's just do both of them, and they can talk to each other saying, this is not this, but look at that policy for questions about EMDR, et cetera.
Okay. I'll share my screen so everybody can see what we're all looking at the same time. And you all can see that, okay?
I can see it. I can't read it. I'm
Uh,
trying to bring it up on the other computer at the same time, so
Okay.
I can make it as large or as small as I need to.
That better?
Yeah, I may have to take my glasses off just because I can't find a focal point that accommodates both of them.
Just find out the words.
Yeah.
Okay.
And I can't remember which mouse pad I'm supposed to be using on which computer.
I've had that issue too. It's a little bit frustrating.
Mm-hmm.
Seth, I'm just gonna do a couple of kind of grammar things.
Go for it.
It looks good as far as I can tell. What is everybody else thinking?
Yeah, I
The
think
interesting
it's
thing
fine
about
as
researching this. Sorry, go ahead.
Oh, I was just concurring.
The people that train that rapid eye technique are in Salem. Like the woman that founded it, that like created the old concept, is in Salem.
Really?
I can't remember what her name is. It's something French, like Renandu or something like that. But apparently she started, and there's rapid eye technique and there's immediate release technique, and there seems to be a little bit of overlap of the two.
Mm-hmm.
So basically, but I mean, but there's no barriers to anyone getting trained in this, because it's there's not a lot of literature about it. I think it's the old, if you want to learn more, take our course and get certified. But it's basically marketed to like anyone who wants to use these techniques. There's no, like the EMDR, you have to be some kind of mental health care practitioner. Because it's much more complex and much more like guided therapy. And I've done EMDR, so it is much more complex. You need to have somebody trained in it. But this IRT stuff, I feel like it's a little questionable, I'll be honest. But there's no barriers to anyone getting trained in it.
Okay. I mean, does the first paragraph of the policy itself get to that point? Is that clear enough, do you think?
I think it is.
Yeah.
I think it sounds good.
Okay. Morning, Lisa. What do you think? We're just looking over the IRT and oh, you're on mute.
Good morning. I have a question. Maybe it was already addressed, but accredited training organization, is that so accreditation is a kind of a complex thing, and any accreditation organization generally also needs to be recognized by something. I mean, so that is anyway, that to me just
That's a good point.
That's a term that is
accredited by who?
Complex.
Who is accrediting the organization?
Mm-hmm.
Yeah, so you have like the training organization, it's accredited by something else, and generally that something else is then recognized by
it's like
something
CCE is
else.
recognized by I forgot what department of the federal education.
Yeah, for our standard
the
education, it's
credibility
the
to
U.S.
CCE.
Department of Education.
Yeah, that's what gives the credibility to CCE being an administrative
Right. In that stuff,
control.
yeah.
So yeah, who's accrediting the accrediting agency, or what background
Well,
does it
just
have?
take out the accredited training organization and have it read: the licensee must, however, be trained and certified and maintain
Yeah.
active and current certification.
Well,
Yeah,
then
and
it
then the
still
board
comes
can
down to who's
determine
issuing
what they think.
it still comes down to who's issuing the credential or certification.
Well, that group that's in Salem, they don't show anything. Like I mean, they
Yeah.
basically are accredited by themselves, but I
Mhm.
think they're the only ones that train in it.
Well, it becomes a gray area if you put, down something that says certified, but there's no basis for the certification. It's a thought I hadn't given any, consideration to till Lisa brought it up. Maybe we, can just kind of put that in a question mode as we, and force it, sort through it a little bit as we go through some of the other stuff. I don't know. It's just, it may need to be revisited.
You could say must be adequately trained, and then it's determined by that, whatever that board is. Just adequately trained. You could take out certified.
Mhm.
And then the board will decide if that
Well,
person seemed.
if that's the case, maybe we should also take out maintain active. Yep.
Yep.
Take out all that, because that just goes along with the training and certification, if there is certification.
I also have
I
another
don't know
question.
enough about the IRT, to be honest. So
Was IRT and rapid eye technique actually, like, was that a question from an organization? Was that, or a person? Was that requested, or did it kind of come out of the EMDR?
I believe it was within the original P&P.
Okay.
Let me pull it up.
Okay.
Of course, it's taken a while. Give me a sec.
Computers aren't awake yet.
I don't think any of us are either, so it's all good.
They must have been awake. They're out on the freeway this morning.
Other people?
Oh,
Yeah,
man.
it was busy.
17 was a parking lot.
Yeah.
Okay, maybe it's there it is. All right, so let me stop sharing so I don't make you guys sick, and I will pull this up. Let's see if I can find it here. Yeah, okay, so here, let me share again. Can y'all see that? So this is what's still within the original P&P.
Okay. Okay, perfect.
That get to your question, Lisa?
Under the investigational rule. Okay. So rapid eye technique is not a chiropractic procedure, though.
That's the other one, right?
So do we need to? So are they two separate things? Because it looks like they're interchangeable as it's written here.
I'm not familiar with either one as what they are, but it looked like from that policy from that determination that you had up earlier, Cass, that
Mm-hmm.
the IRT was accepted, but the RET was not.
Neither one of those groups really give a lot of explanation about what it is. But the thing is though, but the thing is, like, none of them have any kind of qualifications. Like, you have to have a bachelor's. You have, I mean, like, literally
Yeah.
anybody off the street can get trained in this. So I don't really see any reason that we can limit it with any kind of grounds to say, oh, but you're a chiropractor, you can't do this.
Right.
It's like Reiki, like nobody has to have some kind of qualification or a bachelor's in kinesiology to do Reiki. You can just wake up and say, you know what, I'm going to be a Reiki practitioner. This is the kind of same thing. Versus EMDR, that very much like you have to show your credentials of some kind of your psychoanalysis, psychiatry, psychology, mental health practitioner before they'll even let you take the course.
Yeah, it's interesting. So clearly this was from 2008.
That's so long ago.
It's so long ago, and so I'm not really sure. Clearly the board at the time thought RET was not a chiropractic modality. But now let me look back at how this is written. So the title of it is and but then we have or here. Either.
Yeah, we're calling it interchangeable the way it's written here.
Uh-huh. I would say let's just do this. I think we get there if we just make those changes. Combine.
I mean, that first sentence under the policy may need to read the utilization of IRT, but not RET in clinical practice is within the scope.
I like that. It's very concise.
Okay.
And then it goes on, however, the licensee must be adequately trained for IRT.
Mm-hmm.
You can take out techniques. I think that second paragraph is fine.
Yeah. Yeah, I think that makes it much more clear.
And we could include in there, we could keep the investigational part for the IRT that was determined, I guess, in 2008.
Let's see.
Seth, you looked up both of these, I assume, in putting your draft together. Did you see a distinction between the two in the current material?
No, not really. And the group that does the training is called the Rapid Eye Institute in Salem, and they teach the rapid eye technique. And IRT is this other little kind of caveat to it, but there's a lot of similarity.
Yeah. Well, I mean, it's possible we could publish this draft or whatever, or the board could send it out for public comment. And if there's enough brouhaha, then we could send it back to that alphabet committee.
Yeah. Well, I mean, I think this is a good draft to pull forward as written. So if everybody's agreeing to have this move forward to the board, so we can get it to July's meeting.
So in the second paragraph where it says these techniques are not to be confused, you're referring to the IRT and the RET?
Mm-hmm.
Okay.
I'm on their
I'm
website.
I'm reading right from this training, this group, right? Phase 1 course is detailed learning of the RET immediate release technique, emergency process, and self-care. Course includes cognitive concepts, study skills, and hands-on practice. Immediate release technique is a stress relief tool designed for processing sessions. So there's a lot of like back and forth. And this apparently is the group, this woman is in Salem. Apparently she is the one who's created it. Her name is, where'd she go? Oh, fiddly stick. Yeah,
Do we know-
Renee Johnson, founder, author, and owner of Rapid Eye Institute.
Do we have enough to maybe call one an AKA of the other? So immediately technique, also known as rapid eye technique.
I don't know that they really are. I mean, the way it phrases it, it sounds like RET is the overarching, and then IRT is a subcategory of it.
Okay.
I agree with where Seth is
super
going.
weird.
Like you're saying that, you know, that they shouldn't be separated out. However, I feel like that ETSDP committee made their determination and we might be kind of stuck with that for now unless it goes back to that committee for that kind of review.
I say send it forward, let them review it and see what they say.
We can do that. So we'll just move this forward as is. I'm going to stop sharing so I can save it all.
And because when you look at this, it says like register, no prerequisites. Okay.
How much are they charging?
Download registration form.
Oh,
Doesn't actually show the price. I feel like
All
this is
pricing.
kind of up there with that tapping therapy.
Yeah, that's
You
yeah,
know,
it
that's
seems
like there really is no qualification. You know, like it's
oh, there's a registration form. Let's see what that does.
learn RET.
Come on, load. Okay. Full course 600. Materials are
Wow.
5,700.
Wow.
You're on your way.
for
Yeah,
something that we don't know
but-
what it is. That's pretty.
But
pretty
it
awesome.
does, this does make a distinction between an IRT practitioner and an RET technician. You become the IRT practitioner when you do the first phase of the training, which is 20 hours, $1,200 plus $25 and no other tuition cost. So there is a distinction between the two.
Yeah, there is. They just don't really delve into what the difference is.
Oh, and then we also have to pay shipping and handling.
I think it's how much money you pay. I think
Yeah,
that's the
right.
difference.
I mean, as far as I see, the only qualification is students must be at least 18 years of age at the time of enrollment.
So someone could take
That's so
this
they can sign the
course.
contract.
Someone could take this course and maybe turn around and offer their own teaching
Uh-huh.
venue. I mean, if there's no credentialing, right? I mean, is
It's a
that
pyramid
true?
scheme.
Kind of.
Okay, well, moving on then. So IRT, RET is going to the board. And
Where
then
are you
let's
going?
do the EMDR.
EMDR.
Pull that up.
Now, EMDR is very, very different.
So what makes this different for a layperson like me? What makes this different?
EMDR is like guided therapy. It's based off of a woman's work. Her name was Shapiro, and you use eye movement, and there are different techniques. You can either use like a light board where you follow it, but you're basically guided, and there's an 8-step process. And the therapist walks you through whatever trauma you're trying to overcome. She developed it for post-Vietnam syndrome, like PTSD Vietnam veterans, but it has now been used for any kind of like trauma where you have to cognitively analyze the emotion, and the eye movement helps you process it and kind of deal with the deeper levels of it so that you can analyze it and process it like you do when you're sleep. It's basically trying to mimic REM sleep where you're processing emotional trauma, but the therapist is there to kind of guide you through it.
Okay.
So that's why I think they limit it to more to like a psycho thing, because I don't know, the RET stuff, that stuff is like, I don't know, man. But the EMDR, you have to have some kind of a level of training in psychology, some kind of counseling, so that you can help that person work through their trauma. And they really do. Like when you look up EMDR training, it's very much you have to have
See.
some kind of credentials that show that you have a background in mental health, whether it's a licensed counselor or a psychologist, something. You got to show you've got experience in mental health before they'll let you do the training.
Okay. No, that totally makes sense.
And that verbiage from the description of it, I took that pretty much directly from the EMDR, like the EMDR Institute describing what it is.
I think it's
I've-
good. I mean, usually for these policies, we try to keep it as concise as possible, but I think to include some of the description in conjunction with the other policy that we just had, I think it helps distinguish them for sure.
I
And
tried
it
to
doesn't
keep
take,
it concise.
yeah, no, I think it's really good. I don't see any changes that I'd make, but anybody else?
I'm good with it as well.
Awesome. Then let me stop sharing this one and let me save it. Remember the last time I didn't save. That will haunt,
Yes.
that will haunt me forever. That will haunt me forever. Oh, all right.
You wake up at night screaming, Control S, Control S.
It's true. Let's see. All right. So now let's pull up Dr. Kouzis. And I have to say that Lisa, you got this to me in April, and I completely I had it filed away safely for the P&P committee, and I did not at all
So
look at
that's
it.
also the last time I looked at it.
So it's it
And
was sitting here.
I do want to discuss. I want hearty discussion. This is a total draft. Okay. I mean, it might be good. There might be parts that are good, but it's a draft, and I would love some back and forth and fact checking. I think it
for
kinda
like
works,
everyone's
but let's
for
try it.
history, if you guys remember in the February meeting, there was in the P&P itself, there was a whole slew of these different studies, lab studies, diagnostic imaging, sleep studies. What else was involved? It was surface EMG, and the question was, do we want to bring surface EMG and needle EMG into this policy? The ascorbic acid test, the pulmonary test. I mean, there were all these different individual tests that were touched on in the P&P. And so we said, well, why don't we just create just an overall diagnostic studies policy? And so that's where all this originated. And I think, Lisa, I sent you all of the little tiny snippets from the P&P of all those possibilities.
Yeah.
And so we wanted to get it as general as we could.
And there's some heavy lifting with a few sentences in here that I don't know if we want to like emphasize more, but okay. So under policy, so I looked at our rules, and I don't remember if I looked at statute as well. I had a couple things provided to me from OBCE. I decided to take out that part as taught in approved chiropractic colleges because I felt that was limiting. It's like, well, yeah, that's already in the rules or I don't remember which one, but that's already there. But to me, that seems kind of limiting. I feel like we can use more if it's reasonable and it's being used appropriately and the chiropractor has adequate training. So here, so per the statute, any active Oregon licensed chiropractic physician may utilize, quote, all recognized and accepted chiropractic diagnostic procedures. And I wanted to define what that was. So all recognized and accepted chiropractic diagnostic procedures are those diagnostic tests, etc., intended to and capable of. So capable of is doing really heavy lifting here. Intended to and capable of informing the diagnosis, choice of treatment, and or referral of a patient by an Oregon licensed chiropractic physician. To me, I feel that this allows the board to evaluate the intent of the procedure and if that procedure or diagnostic test was capable of. And I feel like, there's all these kind of interesting, weird tests that are advertised to chiropractors. I think the Bax 3000 is another one on today's agenda. That come up time and time again. And some of them are complete pseudoscience. So it's like, well, it also needs to be capable of informing those key reasons that any diagnostic test would be ordered for. So that's kind of the language that I came up with there. And then the rest just really just follows what our trends have been in the different categories.
Yeah, problem becomes what is recognized and accepted chiropractic procedures, who's recognizing it. You may have one organization that says, yeah, this is the cat's meow, and there's nothing to support it.
Yeah, it's tough language, but that's the
Yeah.
language of the statute.
I know.
So
Well,
I try to define it there.
And I don't know if we have any, I know we don't have a rule that explains or defines recognized and accepted chiropractic. I mean, we don't have a rule that does that. I don't know if we have case law. The most recent case law that we had would be the one determining that, and in case law meaning from the appellate courts, not just from ALJs, but from the appellate courts would be our dry needling case that
Yeah,
went
that's
into
for treatment.
Yep. So
But
I
that's the
can't,
sort of thing we're
yeah, I
looking
can't
at.
come up with any more recent cases that would define if that was defined at all.
I think that was one of the reasons why we had the original language as taught by the chiropractic colleges, but even that can be, questionable depending on, some of these classes that are being taught under the auspices of a college's continuing ed may not have substance behind them either.
Right. And I'm a little concerned about deleting that portion of the citation of the statute, just because we, as the board has relied on, I mean, to your point, Tom, has relied on that piece of, well, is it taught in schools? If it's not taught in schools, then it's kind of the threshold, the requirement, like, is it taught?
There's one cutoff point.
Yeah. And so I kind of want to leave that as a threshold. If it's taught then the school, then is it also recognized and accepted? I don't know. What do you think, Seth?
I think I agree that the recognition part is a slip. It's kind of like on the IRT thing, like the accreditation. So
that's exactly this.
Yeah.
That's statute language.
I know.
I mean, I think I know, but that's the thing is, like, we can't change it without changing the statute. So we're kind of like hands tied, kind of.
Yeah.
I think the board interprets it.
It is kind of like the Bible.
Yeah, and if I take out, or if it's lined out here as taught and approved chiropractic colleges, it's not actually taking it out of the statute, because you can't take that out of the statute. It's just not referencing it here.
Right.
It might need to be referenced. I'm not sure.
Yeah, that's my thought is
keep it referenced.
And so you have the quotes closed here, Lisa, but the actual statute goes through this, right?
And I believe there's some other words in there, because I have ... So let's, if you have it, I don't have it, but if you could pull up that statute so we can see the whole language.
Yep. Sorry, what are we looking at? 1684. 684-0102. Chiropractic is the system in minor surgery.
Rational therapy measures as taught in approved chiropractic colleges. All recognized and accepted chiropractic diagnostic procedures. And the employment of all rational therapeutic procedures as yeah.
Oh, here, this is where you got it from. Sorry, I'm
Mhm.
catching up. I'm
Yeah.
catching up.
Yeah, it's B.
I love all rational. Rational by who?
I know, it's a tough one.
But I think we should just keep.
Recognized and accepted.
I think we just keep the original
The whole
Verbiage.
thing.
verb in there, just so everyone can see how odd it is, really. And not the same size, is it? Oh, okay. Anyway, so there's the full.
And then put quotes after colleges, yeah.
Got it. Thank you.
Yeah, and the current language should be chiropractic programs, as as what CCE is trying to really just get all the states to change.
Mm-hmm. Now, so would this be here, Lisa? You have diagnostic procedures as what was referenced in the statute. Would this
Mhm.
need to be diagnostic procedures here?
Yeah, that would make sense.
Yeah.
So would this be diagnostic procedures policy, or would it be diagnostic studies?
We can do procedures to keep the language the same. Yeah, I think that's the same meaning, so go for it.
I lost tracking somehow. Okay. I think that's a little bit clearer as to our meaning.
Mm-hmm.
So then let's get down into nitty gritty. I'm going to get rid of the statute just because we already have
Sure.
it now.
So I still think, in that second sentence there, I still think that really any justification for using diagnostic procedures would need to be, there's an intent that it's going to influence diagnosis or management, and that the test or whatever it is capable of giving you that information. So I really think that is what it boils down to. And intent is probably easier to show because, unless there's no clinical rationale in the chart notes and the intent was just to fill their pockets with money. But really, is it capable of giving that information? And that's what, I think a lot of times, if you're looking at what kind of diagnostic procedures are inside or outside scope, is that with the chiropractic profession is more like it needs to be evidence-based and credible. And in general, I would feel that if it is a credible diagnostic test and someone was complaining about it, then it was like, well, can a chiropractor do that? Is it within scope in a sense? And then that's where the adequate training comes in. So there's the adequate or appropriate training is incorporated in the bullet in the list below. So thank you for looking that up. I knew there was one.
Yeah. Well, and would it be facility? I guess it's CLIA is facility.
Facility or equipment.
Yeah.
Yeah.
I like the distinction between their own patients and then also for ordering clinicians' patients too. I think that's really good.
I found those in some of our other policy guides. So yeah.
Yeah, I agree. I like that because I've definitely had people sent to me for like blood work and stuff like that, and they're not my patients. They just need a blood draw done. So that's super handy in there.
Yeah.
Hi, Mike. Good morning.
Hi, good morning, everyone.
Hi, Mike.
So how are we with, so we're looking at the diagnostic, what was originally the diagnostic testing policy, but now has changed to diagnostic procedures policy. And I think the perform section is great. And really, I do appreciate, Lisa, you're segregating out the perform, order, and interpret. I think that's a really good way to do it too.
And then
Really
there's
good
one more.
organization.
I think there's maybe one more category.
Integration.
So I took these from other that list, that just the bunch of stuff that you gave me. I found it in there and brought it out.
Do we need to have integration up in the issue or no? So you have perform, order, interpret.
Oh.
Not really, huh?
No, I feel like
Okay.
the integration it's like to remind people that that's the standard of practice.
Yeah. Okay. So I think perform is good as edited. How about order? And I'm liking that you're distinguishing active versus inactive too. I think that's really clear.
I kind of don't want to limit it because it goes back up to what was the intent, and it must be for either, the diagnosis, the management, or referral. So I really feel like we should be able to order what we need to. I don't feel like limiting, it's for a board's interpretation, but I just kind of feel like as long as it meets that criteria above, then
yeah, I guess my point was though for active.
yeah, for the active, yeah. I'm just bringing up if anyone wants to question any type of test modality, special test. I mean, if you want to order a crazy expensive test that is lacks any any evidence to support it, then it doesn't, you can't order that test because it's not a recognized and accepted diagnostic procedure that is defined right there. So I feel like it covers that.
I think as long as you have clinically indicated, yes, that would,
Or maybe we could draw it back into that top paragraph. May order any type of da 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 da. Oh yeah, it says that is clinically indicated. Yeah, okay. Okay. Good.
Okay. Order looks good. Interpret. Which they're appropriately trained.
So where you have in the second paragraph, any active Oregon licensed chiropractic physician may interpret any type of diagnostic imaging modality. I don't think, at least my students weren't trained to look at CTs and MRIs to be adequately trained. They got, the information from it, and usually from the report of the facility performing that, but they don't really interpret that or the ultrasounds. I mean,
yeah. So that last sentence may
Yeah.
help you with that, and then the highlighted portion of that middle sentence. So basically the top sentence is every diagnostic procedure needs to have an interpretation.
Absolutely.
And any chiropractor can provide that interpretation if they're adequately trained for it. But you also may defer to it to a specialist to interpret for you.
I think what you're saying is that the chiropractor ordering the test has to at least acknowledge that he's received the results of it if he doesn't perform his own interpretation, and how that affects his management of the case. Or her
Yeah,
case.
it's like if you perform diagnostic ultrasound on your patient and for some reason you're not trained in interpreting or whatever, they have to get an interpretation of that. Whether from
X-rays
you
in your
or
office, you have
specialist
to
or
provide a report for it.
yeah.
And if
there
you
has
send
to
it
be a
out to an
report.
imaging center, you get it back. You wanted that for a particular reason to decide something as far as treatment, then you should acknowledge that and say, I reviewed the films. There's nothing to suggest a contraindication to whatever, or to change anything in the original proposed treatment plan. Something that acknowledges that you saw and that had an influence on your management of the patient.
I guess, the question I had here is it too ambiguous? So a physician may interpret any type of diagnostic imaging or laboratory or special test for which they are appropriately trained. Some chiropractic students, at least that I've had at Palmer, they feel as long as they were exposed to it, now they are trained to do it, which is not the case, So their interpretation that they were appropriately trained for it versus are they really? I guess that's the part I'm having difficulty. Who is to say who's appropriately trained for that?
Yeah, I totally understand that. And I think it's the board interprets that, and we have to go on trust that the majority of chiropractic physicians know what they're trained and not trained in. But the board will interpret if they're appropriately trained or not. At least that kind of situation comes up repeatedly, and that's kind of, at least in my experience. So
Yeah.
All right.
I respect your faith in our fellow practitioners.
Say what, Seth?
But I respect your faith in our fellow practitioners.
yeah.
Trained.
That's kind of how it is, though. I mean, yeah, and unless you want to, I think it's too much detail. Like, I don't know that it can be put in words for every situation and every kind of thing.
It's like trying to legislate morality. Like, it's just never going to happen.
Yeah, it's a tough one.
Okay.
What do you think about instead of having integration as that same kind of bold kind of heading, change it a little bit? Because what Tom was saying goes right into interpretation. So integration, so he was just saying it has to be, you have to put it in there and integrate, and it's a standard, and maybe it works just getting rid of that header.
Just get
I don't think it's a separate entity. It doesn't look like it's necessary. If you just, move that paragraph up.
Yep.
And then we also can address that first issue that you were talking about, Cass, with like, do we need to add that language? So yeah, we just get rid of the integration. Okay.
Oh, we don't want it that close. There. That works. Okay, now as far as CAs.
Oh, heck.
I had a quick question about the interpret. Should we put in there that a report must be made?
I don't know if
an interpretation report.
Yeah.
So it must be accompanied by an interpretation report.
Oh, good. It's in there. Okay, great. First sentence.
Does it say report specifically, or does it say incorporated into the clinical record? Because
both. So it says everything must be accompanied by an interpretation report.
Okay.
And then the integration, oh, where did it go? All
Management
available
plan.
like results must be integrated into the patient's evaluation and management plan.
I'm just
So you-
wondering, say you had a lab report that came back, you'd have the printout of the lab report, what the values were, and in the chart note itself, you might say that, there's an elevated white count that, we're referring to the primary physician for potential antibiotic treatment or something along those lines. Would you need to, would that printout be the report that you're talking about and you've just incorporated into the note? Or would it say somebody who takes the x-rays in their own office comment on them in the chart note for that visit where they outline the same things that would be in there? Do you need a separate report in that case? I know you need.
I think the interpretation report is like the findings.
Okay. So if that was incorporated into
and then
a chart
there's
note.
the incorporation of that information into your evaluation management, into, what are you doing for the patient? So I think in both, in your first example with the white blood cells, you got the lab report,
Mhm.
and then you did the incorporation component by saying we should refer,
I'm
because of
just
those
thinking
results.
like say somebody does x-rays in their own office
Right.
and but I believe there's an x-ray regulation somewhere that says that the films themselves have to be accompanied by a report. So
Yep, it's true.
then, it's a moot point. You're still going to have a report. So,
Right.
okay.
Yeah. It still fits that first sentence.
Yeah.
And then using that information and showing
Mhm.
your clinical rationale. That's also specified somewhere else in rule or statute.
Yeah.
It's like the clinical justification or something, like, but it just kind of says it here just because
Mhm.
it's all the components of what diagnostic procedures are for and how to use them.
Mhm.
So yeah, I think it's good.
Okay. For CAs.
Something I would, the third bullet point right there, I would
Mhm.
put an or in there. So perform special tests with appropriate certification or training. I would just say or. And so, yeah. Oh, same way with the middle one, certification or training. And that one,
Why or? I think and training is better because say the chiropractor says, okay, you could take radiographs and I'm going to show you got training under me. I would rather, I don't think just anyone could take radiographs or pull blood or anything else. I think they do need certification and training to do the procedure.
kind of. So I agree with you. Maybe the laboratory tests we can say and so the radiographs I believe are regulated. So that one I think can stay. Laboratory stuff. If you just collect urine in a urine cup and do the dipstick, do you need certification?
Well, not for
Can a
that, but
CA
pulling blood,
look at
you
the
certainly
dipstick and
do.
do the?
Yeah. So, or fits that.
I think, and we could put it training or certification because that feels better.
Yeah.
Training or certification. And then with special tests, it's such a broad, it's a catch-all for everything else. And I believe, so like, let's see. CA, well, I guess the board hasn't decided yet what the scope of practice CA, like, I don't know if it's written yet. I don't know if the language is out there, but they can do pulse and blood pressure. I mean, those are tests. And I would say maybe those are special tests. So, but there's a lot of little tests you could do. Like, isn't it possible you could train your CA to measure range of motion and just write it down? Like, you could have your CA. Maybe I'm
I don't
wrong.
know. Again, I wouldn't want a CA doing those functions without any kind of appropriate training. I mean, I
Yeah,
think just
I agree.
training, you know, is you have appropriate training, but who is to say what is appropriate training? If you're in a class where they offer certification that they did all these things and we've overseen that they know how to do all these things, that's different than just having,
But
you
what if
know,
there's no
Tom, Dick, and Harry
certification
tell you
for,
how to do these things.
what if there is no certification for that particular training function?
Well, don't
Yeah.
CAs go through a training course, how to do all this stuff?
But
Don't they
there's
end
some
up with
things,
certification?
there's some things within that CA approval that are limited and dependent on what additional training they get from the doctor.
Yeah, it's kind of vague.
Yeah.
I don't know. It's
Yeah, I agree with you.
I don't.
I
Feel
agree with you that
to be honest.
it seemed, you know,
Would it be helpful actually above it to say under the order of and direct supervision by? Because
Well,
here
it
it
might
says
be-
just under the order of the supervising DC, but it's not, you're not addressing whether they're actually supervising you doing it. But I mean, they're supposed to be.
yeah, it's kind of that's yeah, so it wouldn't really so Cass, can you remind me, is it in the rule direct, does it say direct supervision or does it just say supervision? Because man, it's different for so many different states and I just can't remember right now. Some states say as long as the chiropractor is within like 5 minutes, so they could be like literally out to lunch, but if they have their cell phone with them and they
Yeah,
come back,
ours
that
is
would be
interpreted
okay.
to
Is
mean
ours on the premises?
on the premises.
On the
Yeah.
premises.
Yeah.
So it would be that, and then, you know, if the chiropractor had to be in the room watching the CA do it, there's no reason to
Right.
have the
That they
CA do
shouldn't
it.
do it. Yeah.
Yeah.
So I think would just be on the but that's supervising. So,
Yeah.
well, I mean, that's theoretically understood under what a CA can do at all.
What is the argument against just having within their scope of practice?
Oh, I like that.
Say that again. I couldn't understand a word.
I'm just wondering what the argument is for not just using scope of practice, that the CAs have completed the training and they have a scope, and it would seem like they should be allowed to use whatever that scope is for that. And why wouldn't we want to do that? That also would allow flexibility for the future. Should the scope of practice be increased, they would automatically, be there. But I mean, that's usually what everyone looks at. Are you practicing within your scope of practice, or are you not?
Yeah.
So,
I think
so that first, are you saying that first sentence, a certified CA may perform diagnostic procedures that are under their scope of practice?
Yes.
Okay.
I mean, it's simpler, but I mean, it's kind of what everything is based upon, I think.
Well, don't delete that yet. So may perform, so there, right now there's no imaging, right? That would be under the CA scope of practice.
Right.
Are there any laboratory tests that are under the CA scope of practice? See, I think I might replace the any imaging laboratory or special tests with just diagnostic procedures. So a CA may perform diagnostic procedures.
Under their scope of practice or within their scope of practice.
Yeah, within.
I'm wondering
Within-
what the training, because the training for a CA is a lot of modality and medical terminology and gowning. It's pretty basic, and I'm not sure if I just don't understand if I know what the scope of a CA is and how to bring diagnostic and laboratory studies into that, when I don't think that that's part of that initial training that's a requirement for a CA, and how many hours is required for each.
So I would think that blood pressure, heart rate,
Vitals.
vitals,
Yep, those are
height, weight is within the scope.
I agree.
And I don't know if the CA scope of practice is defined yet by the board. Maybe, maybe we say here a CA may perform diagnostic procedures within their CA scope of practice, such as vitals, height, and weight.
I wouldn't even put that. I would just say within their scope of practice. And then, you know, I mean, because that says everything. Instead of spelling out some things and not others, what they can do, I think it's best just to end it there.
Well, and I know in previous policies and rules, we've actually avoided a CA scope of practice because they can't practice on their own. And so we've said the duties of the position, the duties of a CA. So either
can you use that language?
Yeah, within their CA job duties.
Yeah, within the duties of the position or job duties. Yeah. Okay. Okay.
Okay, so who defines the job duties?
The board.
So are they certified or are they not? They are certified, yes. The course.
They are, and I think we ought to use that because
it says
very
certified
specific.
Assistant. Yeah.
Yeah. You know, I mean, I understand that the board may have to do a little bit of work in figuring out what exactly the scope is, but I would have thought that work would have already been performed. So I guess I'm wrong about that part. I mean, you know, if you're certifying someone, it seems like that somebody somewhere would have said, yes, you'd have, this is your scope. Don't go outside of it.
Right. I agree.
I think they're partially defined, but I don't think the edges. I mean, just I think it's pretty clear that they can do vitals and stuff and height and weight, and that they can you know, do that.
And that's partly what we're doing here as part of the P&P. I mean, so that's
okay.
Yeah.
Okay.
Well, this would at least make it so that the board could easily define the duties, and this is already set up, you know, I'm ready to go to accept whatever they consider to be within the scope of practice, and that probably needs to be done.
And I think we can get rid of everything else. I think just having that statement is enough.
This is what it looked like. Within.
Yes.
Does that work?
I think so.
I think it works. It's going to refer to, to job duties and wherever those are stated. Yeah.
Yeah, that's the one part that I'm a little not as comfortable with, because by referring to job duties, there's lots of different types of job duties that doctors might say, oh yeah, that's part of your job duties, versus actually saying within their scope, you know.
Well, it has, scope of their job duties. I guess the point of the language there is that they don't have a scope of practice. maybe that's what it is here because they can't be, they're not independent. Is that what it is, Cass?
Yeah.
Yeah.
But they really do have a scope of practice. If they're taking the course, that is their scope of practice. That is their official, knowledge base that they're working from to perform their job, So
But if
while
the
it may
board
not be
doesn't use that term,
standalone, I still think there's a scope of practice that they.
Well, and we can leave it. I mean, one thing that I do when I present these to the board is that I'll present this red line copy and I'll present the clean copy just so that the board can see kind of the transition of what's been reviewed. And they may, I mean, who knows, but the board may come back and say, yeah, let's just leave scope of practice in there. So I think it's a good question for the board to move forward with. But as this stands, I think it's a really great kind of all-encompassing general policy. Lisa, you did a really great job on it.
Thank you.
So are we good with
Excellent work. I think
this draft?
probably with scope of practice stuff is that the people that do CA training, whenever we tinker with that, it becomes a hot button.
Yeah.
And that opens a whole can of worms that we have to address that becomes this contentious matter of, well, what can we do now? And it's hard to avoid. It can't be avoided, but still, I'd love to avoid it as much as possible.
I wonder if the board would consider doing a policy and practice guide question on what are the job duties of a CA and then answer that.
Well, we're
In a
right
separate
now,
thing.
we're reviewing and finalizing the CA study guide for the initial exam. And so I think with that work, it's pretty much clear what that is. Yeah.
Okay.
And that's a
Yeah.
lot of fun.
Oh,
Yeah. But it could be another one of these policy pages, I think,
Yeah.
To address that question. Yeah, that this one could then refer to in a sense.
so just creating a CA scope of practice policy.
Yeah.
Okay. Yeah, we can ask the board that. But as this stands, I think it's great, and we'll move forward with this draft for July's meeting. I'm going to stop sharing our screen so I can save it. And I don't think we don't have any other policies to review today. Like I said, I completely dropped the ball on the things that I was supposed to bring forward. So thank you everybody for picking
You
up
had
the
other
pieces.
things? There's other things on the pipeline?
There are other things in the pipeline. And in the meantime, when Seth and I meet, not today, but in a future meeting here in a week or two, to go over kind of what we did last meeting and my policies that I need to create, we'll also do a fuller review of what's standing the left in the P&P and see kind of what policies remain. And I think maybe Seth, do you and I just want to kind of divvy up and assign folks policies to look at, or do we want to spend another meeting kind of divvying up?
I think Lisa should just do them all. I'm just, gonna.
I need some kind of stipend. I need, like maybe
Really?
maybe if I get to go to like a spa or something,
There you go. There you go. When you flex the muscles, then you get asked to pick up heavy stuff. That's why I don't work out. No, that sounds like a good idea, Cass. Yeah, totally.
Okay. So I guess my point is, everybody, so just expect a kind of an assignment email from us in the next couple weeks. And I look forward to Heather, when's our next meeting?
Let me look real quick.
August 22nd.
There you go.
There we go, August 22nd. So
22.
We will see you then, and have a safe and cool summer. Hopefully fire-free for everybody.
Oh,
Yeah.
seriously.
Yeah, good luck with you.
Yeah.
Good seeing
Thanks,
you.
everybody.
I'm off.
Okay.
I've got a,
Cheers.
before you leave, am I talking? You getting out?
Yeah.
I've got a question to the group that I routinely teach a continuing education class that covers things like clinical documentation, HIPAA, cybersecurity, and I've asked Lisa this a number of times over the years. I'm always looking for different topics. Is there some area that you guys are aware of that seems to be lacking, that needs to be brought up in a continuing education class?
I had thought of this, Tom, and I'm sorry I didn't get back to you. I had been thinking about it for a while, and you know what? It's AI. So there's new and some standards that are forming. And so if anything is AI generated, I think what might become a standard is to identify that something that AI was used. Just to know AI was used for something, you know, so it's becoming more prevalent with imaging studies, and it may become the standard because it improves accuracy. But it can also be, what's that?
What?
I said, there goes my job.
No, it's actually
We're done.
it's combined. Combined is best. But it can also now there's a lot of AI programs out there trying to capture the conversation between the patient and doctor and write the notes.
Oh, wow.
So yes, it is happening.
That'd be a great
have a
continuing
physician.
education lecture.
I have a physician that is trying all this stuff. It's fun. And so, but so that's on the horizon, and that would be awesome if it worked and was accurate. But
Do
it
you have
needs a
any
disclaimer.
web links or articles that you've come across? If you do, send them to me. If you don't, that's okay too.
Yeah, let's see. The FCLB had some speakers on that. I might be able to get that for you.
Okay.
Yeah.
It's a brand new topic that would be great to include. I hadn't even thought about that.
It's a good one.
I know you guys were discussing the next meeting. I know it's sometime in August. I am having surgery on the 13th, going back in for another laminectomy. So I will more than likely be bedbound for that meeting, but
but I'm sure we'll see you.
Well, best wishes, Tom.
Yeah,
It'll be a great outcome.
Yeah.
Yeah. It's about the fifth time they've been in, so it's a different level.
Well, I hope so.
It keeps moving up.
What a
We're at
surprise.
L1, L2 this time, so.
Oh yeah. Oh.
So.
Yeah, we'll be
Okay,
thinking
well,
of
take care, you guys. I'm signing
All right.
off.
Thank you very much.
Thanks, Susan.
Okay.
Thanks, everybody.
Thanks.